It's my pleasure to welcome you to this webinar, which is organized by the Arab Thyroid Association. This is currently the 10th webinar organized by the association. My name is Mohammed Bashir. I'm one of the consultants endocrinologists in Hamad Medical Corporation in Qatar. Today we'll have two speakers discussing two topics related to the parathyroid gland. Each talk is going to last for about 30 minutes, and then we'll have question and answers. The first talk is presented by Dr. Salwa Al-Aidaros, followed by another talk by Dr. Thamer Al-Essay. Please post your question and answers in questions in the Q&A box, and we will have about 10 to 15 minutes at the end of the talk for discussions. So without any further delay, I would like to introduce our first speaker, Dr. Salwa Al-Aidaros, who's a consultant endocrinologist in King Abdulaziz Medical City, and she's also an assistant professor in King Saud bin Abdulaziz University for Health Sciences, and her topic is updates in hyperparathyroidism management. Dr. Salwa, the stage is yours.
Thank you, Mr. Chair, for this introduction and for inviting me. The topic of today is about primary hyperparathyroidism. I will talk about the update. First of all, this is my disclosure. I have no conflict with the content of this talk. I put this slide just to tell you that most of my update was taken from this summary statement and guidelines from the 5th International Workshop. It was just published 2 months ago in 19th of August this year. So the outline of my topic, I would like to cover in the coming 25 minutes about how should primary hyperparathyroidism be diagnosed, and what are the clinical phenotypes of primary hyperparathyroidism, and how should the patient be evaluated to go for surgery or not surgery. And then we'll talk about the surgical and medical aspect of primary hyperparathyroidism and finish with the monitoring plan. So primary hyperparathyroidism, this is a common endocrine disorder characterized by incompletely regulated and excessive secretion of parathyroid hormone from one or more parathyroid gland. It's almost always a secondary to a single gland in 85% of the cases. Sometimes maybe become multiple glands in 15% of the cases, and very rarely the primary hyperparathyroidism is a secondary to a carcinoma. And up until recently, we needed the hypercalcemia to be for the diagnosis of primary hyperparathyroidism. And this is the patient should be hypercalcemic. This is like in the right of this box, and with the presence of elevated parathyroid hormone or inappropriately normal at the setting of hypercalcemia. The pathophysiology of primary hyperparathyroidism is now known as a clonally dysregulated overgrowth of parathyroid tissue with excessive secretion of parathyroid hormone, together with reduced expression of the cell surface calcium sensing receptor. And of course, this abnormality will lead to several effects, like setting the point of calcium-induced inhibition of our parathyroid hormone become higher, and the rate of bone resorption is accelerated, together with the renal tubular reabsorption of calcium is facilitated, and reduced renal tubular reabsorption of phosphate or increasing the phosphate excretion. And of course, with the stimulation of 1,25-hydroxyvitamin D by the parathyroid hormone, that will lead to intestinal calcium reabsorption become increased. So what are the current clinical phenotype of primary hyperparathyroidism? In fact, we have 3 generational phenotype, and it depends on the evolution of the technology. So before 1970, we know that the hyperparathyroidism is a disease of bones, groins, and psychic moons, and we have this what we call symptomatic hyperparathyroidism. And this symptomatic hyperparathyroidism associated with the classical complication of hyperparathyroidism involving the skeletal and renal, and that may include osteoarthritis fibrosa cystica, which is the pathognomonic features of primary hyperparathyroidism, and that include salt and pepper appearance, appearance of the skeletal distal resorption of the phalanges, brown tumor. And the patient also may present with fracture and chronic kidney disease, including nephrolithiasis or nephrocalcinosis. Then after 1970 and in this year, what happened, there is introduction of the screening and involving the calcium in the biochemical screening. With this technique, we noted that there is increase in the incidence of hyperparathyroidism, maybe 5 times the normal. And most of these cases are asymptomatic because typically discovered by the screening. And we call it asymptomatic hyperparathyroidism. And there are 2 forms of this asymptomatic hyperparathyroidism, maybe with associated with target organ involvement or without target organ involvement. I mean that with skeletal and renal complication, with or without these complications. And 20 years ago, after 2000, the year 2000, we started to appreciate what we call normocalcemic hyperparathyroidism. And in that, there is the patient present with persistently elevated parathyroid hormone with normal calcium, and he or she may or may not have target organ involvement. And we're going to talk about this. So, how should these patients be diagnosed? Diagnosed? Of course, the hypercalcemic hyperparathyroidism, we need, from the name, that we need the presence of elevated serum calcium. And it is really recommended to adjust this total calcium for albumin. And also we need the presence of high parathyroid hormone. And the parathyroid hormone, we should utilize 2nd or 3rd generation. And we have to repeat that on 2 occasions. The appearance of hypercalcemia, hyperparathyroidism should be repeated in at least 2 weeks apart and persistent. And of course, the diagnosis is mainly biochemical with the presence of high calcium and high PTH. And in fact, the imaging is not used for the diagnosis, but of course for identification of any abnormal parathyroid tissue, whether it's single or multiple glands. And the presence of high calcium hyperparathyroidism has many differential. Apart from the primary hyperparathyroidism or tertiary hyperparathyroidism, we have to exclude the familial hypocalciuric hypercalcemia, and this is maybe suspected in individual who has urinary calcium creatinine clearance less than 0.01, or those who has family history of hypercalcemia, or those who have family history of hypercalcemia that is not treated or not remit after surgery. Other differential diagnosis of high PTH and high calcium is the using of thiazide diuretics or lithium, and very rarely it may be secondary to ectopic secretion of parathyroid hormone. About the diagnosis of normocalcemic hyperparathyroidism, of course, we need to adjust the calcium for the albumin, or we may use the normal calcium level along with persistent elevation of parathyroid hormone. And when we measure the parathyroid hormone, it is better to utilize it using the 2nd or 3rd generation assay on at least 2 occasions over 6 months. I mentioned this 6 months because the persistency and consistency of normal calcium and high PTH should be elicited persistent in over 6 months before labeling a patient having a normocalcemic hyperparathyroidism. And of course, we have to exclude all the secondary causes of high PTH, and these secondary causes would include the vitamin D deficiency, the renal insufficiency, and again, the medication, including thiazide and lithium, the presence of hypercalciuria, gastrointestinal malabsorption, because it might associated with the high normal calcium and high PTH, and other metabolic bone disease that could be associated with elevated PTH, like Paget disease, which is very rare. It's worth mentioning that, unfortunately, the published study have not always used consistent definition nor regular follow-up at defined point for these patients. So we have some gray zone in this definition and in terms of the definition and follow-up. So how should patient be evaluated after the diagnosis to have been established? And this evaluation, of course, we need to evaluate the patient to see whether he is a candidate for surgery or he would benefit from the surgery or not. And of course, evaluation should include, of course, the confirmation of the diagnosis by a biochemical test and excluding other causes, and of course, to the classical complication, to assess this classical complication in terms of skeletal and renal complication, and maybe the non-classical manifestation, you may evaluate it, and what is the role of genetic in this evaluation. So starting with the biochemical evaluation, all patients should have their 25-hydroxyvitamin D measured, and we have to measure, of course, again, we emphasize in adjusting the total serum calcium for the protein. And if you're suspecting normal calcemic hyperparathyroidism, you may also see or measure the ionized calcium. And of course, we have to estimate the renal function by creatinine clearance or eGFR, because tertiary to exclude tertiary hyperparathyroidism, and of course, to do 24 urine calcium to exclude familial hypercalciuric hypercalcemia. And of course, we stress that all patients should have vitamin D measured, because we know that the clinical manifestation of primary hyperparathyroidism may be more severe in the presence of vitamin D deficiency. And this is alluded from this study back then, when they compare the Chinese population who have hyperparathyroidism with a cohort from New York who have hyperparathyroidism. What we notice here in the Chinese population, they have symptomatic in 90% of the cases, and while the New York cohort was only a few of them were symptomatic. And this explained by the only differences between these two was that in the Chinese population, the vitamin D was very low, and while the New York was sufficient vitamin D. So, and with this study, it was recommended that to keep the patient measure the serum vitamin D, 25-hydroxyvitamin D, and keep it sufficient in this patient, and give them the vitamin D sufficiency, and targeting more than 30 nanogram per ml or more than 75 nanomole per liter is recommended for patients with primary hyperparathyroidism, just to minimize the symptoms or complication. So how about evaluation of the skeletal evaluation? Of course, because the involvement of the bone is globally in patients with primary hyperparathyroidism, it was recommended to assess the bone thoroughly using 3-side DEXA scan, lumbar, spine, and distal, 1/3 of the radius, and together with the imaging for any presence of silent vertebral fracture, either by the imaging, normal imaging, or by vertebral fracture assessment. And you may do also trabecular bone score if available. And this is the skeletal evaluation. And why is that? Because we know that it is involved the bone in all the globally. We know this is usually we thought that the classical bone mineral density features, this is an old features, we thought that it is only affecting the cortical bone, because in this study, it shows that the radius decreased the bone density in the radius, which is full of cortical bone, and the lumbar spine showed that it is normal lumbar spine, normal BMD, DEXA, and the femoral neck was in between. And we know the lumbar spine is mainly trabecular. So with this study, after this study back in 1998, in 1989, when we started to use the bone density as a clinical tool, it thought that with this finding that the primary hyperparathyroidism may be catabolic only for the cortical bone. But unfortunately, this is not the case, because further studies showed that the fractures happen not only in the cortical bone, but also it happen in all sites in patients with primary hyperparathyroidism, the vertebral fracture, distal forearm, rib fracture, and all were higher compared to the control group. And this is also confirmed using a morphometric vertebral fracture study in postmenopausal women who has normocalcemic hyperparathyroidism or asymptomatic hyperparathyroidism or symptomatic hyperparathyroidism. It showed that the vertebral fracture was higher compared to the control group. And the microstructural analysis of the bone also confirmed this. The primary hyperparathyroidism affects both cortical and trabecular bone. So with that, it is recommended that to study the bone and assess it thoroughly using DEXA scan, as I said, 3-site, and by any imaging looking for vertebral fracture, and sometimes you may use the trabecular bone score. So how to evaluate the renal problems or renal status in patients with primary hyperparathyroidism? Of course, we to do the the biochemical, the eGFR, or preferably the creatinine clearance, and to do the 24-hour urine calcium for biochemical risk factor for stone. Not only the calcium, but you may measure the phosphate and the urea and any risk factor for stones. And of course, you supply that with the imaging, either plain or ultrasound, looking for any nephrolithiasis of nephrocalcinosis. Because the renal, you need to evaluate it because it is still the most common complication of primary hyperparathyroidism, although it decreased from 57, but it's still 14%. It's affecting the kidney, the nephrolithiasis, and nephrocalcinosis. And it has been shown that the skeletal involvement is more evident in patients when the eGFR less than 60. And when we do 24-hour urine analysis of biochemical stone risk factors like calcium, phosphate, and the uric acid, these are predictive of a stone in primary hyperparathyroidism. And this stone can be detected also by invasive imaging. So you're gonna do the X-ray, ultrasound of the kidney, or do the 24-hour. This is part of the evaluation of your patient. How about the non-classical manifestation? And with that, I mean the neurocognitive manifestation, quality of life, and cardiovascular complication. But unfortunately, there are no data or limited data to support the routine evaluation for this manifestation. And there is limited data to see the correlation between these manifestation and the benefit of surgery after parathyroidectomy. Why is that? Because this neuropsychological and constitutional manifestation of primary hyperthyroidism, usually the patient come with weakness, easy fatigability, depression, intellectual weariness, and increased sleeping requirement. But all of these symptoms are present in many chronic conditions and lack specificity and really difficult to quantify. And the adequate control studies really a challenge when we study neuropsychological manifestation. And even though with many studies or attempt to see any correlation between neuropsychiatric symptoms, and this is 4 major randomized controlled trials, it failed to see the effect of parathyroidectomy on this quality of life in the patient primary hyperparathyroidism. How about the genetics? In fact, the genetics, it is not recommended as routine evaluation for primary hyperparathyroidism, as it is not required for the diagnosis or confirmation of the diagnosis. But we may use it, and it can be helpful in case of hyperparathyroidism jaw tumor syndrome, because with these patients, we need to have remove all the parathyroid gland because there is a risk of carcinoma. And it's also helpful in case of the syndromic MIN type 1 or MIN type 2, because exploration of parathyroid hormone in the surgery is better, so we cannot use the minimum surgery. And it is helpful in familial hypercalciuric hypercalcemia, because in this particular patient, when the gene confirmed this diagnosis, the parathyroidectomy is not indicated. In fact, it's in the other side, it is contraindicated. And of course, genetic testing, it helps to identify family member who may or may not have or at risk of having hyperparathyroidism. These genetic studies should be considered for patients usually who are young, less than 30 years of old, or those who have multi-gland disease, because it may be associated with syndromic one, by the history of imaging, or those with family history of hypercalcemia, just to exclude these syndromic causes and manage accordingly. So moving now, who would need the surgery? Of course, the surgery, this is not straightforward for patients with symptomatic treatment because it is recommended for all patients with symptomatic hyperparathyroidism who have skeletal or renal involvement. The dilemma comes when patients who have asymptomatic hyperparathyroidism, because with these patients, whether do we do the surgery or not to do the surgery? This is the actual dilemma. But in the guideline, this is the updated guideline from for the treatment for asymptomatic hyperparathyroidism. Of course, patients who have high calcium elevated above the normal, more than 1 milligram above the normal level, or patients who have skeletal involvement that is detected by the DEXA scan or showing osteoporosis with a T-score of less than 2.5 at any site, or he had vertebral fracture that is detected by just plain X-ray or vertebral fracture assessment. And of course, if the patient have renal involvement with a creatinine clearance less than 60 cc per minute, or he has nephrolithiasis by X-ray or CT scan or by any imaging, or have the urinary hypercalciuria more than 400 milligram per day, plus other biochemical indices that increase the risk of the stone. All these are the indication of management of this patient with surgery. And of course, younger patients less than 50 years of age are another indication of surgery, even in the absence of all of these factors. And in fact, patient should, even though who do not meet these guidelines, he might offer the surgical treatment if he doesn't have any contraindication of the procedure. And of course, preoperative localization is mandatory, and of course, adjunct to the parathyroid surgery itself, and using the imaging system scan, ultrasound, or CT scan, but localization is important. And of course, the most important preoperative localization is the hand of the experienced surgeon. And this is known, and in fact, known fact from days ago, from many years ago. Of course, the surgical approach can be minimal or intraoperative parathyroid hormone measurement, or we can have full exploration. As I mentioned, full exploration is called for in case of the syndromic MIN or MIN 2. We have to do full exploration because it may be multi-gland, and sometimes if we suspect multi-gland disease, it is better to do full exploration. So what do we expect the biochemical indices after successful parathyroid surgery? Of course, the biochemical cure, this is the rule, and all of these biochemistry will return to normal after the surgery, and including calcium, parathyroid hormone, the vitamin D and the 25-hydroxyvitamin D, urinary calcium, and also bone marker if you do it. And of course, the parathyroid hormone, usually it is measured intraoperative 5 and 10 minutes following the resection, and adequate resection is confirmed if the parathyroid hormone is decreased by at least 50% and fall into the normal range following resection. And of course, the bone density also post-parathyroidectomy is improved, including the lumbar, femoral, and distal radius. All these bone density will improve. The distal radius may take a longer time because it is low turnover. And this is also has been shown by high-resolution CT scan. It showed that the cortical and trabecular bone, there is improvement in the microarchitecture. Unfortunately, the cardiovascular, quality of life, and neuropsychiatric problems, they are limited data, as we continue to say that, and the surgery has uncertain effect on these complications. How about the bone density after parathyroid surgery in case of normocalcemic hyperparathyroidism? In fact, there is much uncertainty of this in normocalcemic hyperparathyroidism. There is because there is higher prevalence of multi-gland disease than in hypercalcemic parathyroid, and the bone mineral density increases after parathyroidectomy in some cases. And unfortunately, there are limited data on the benefit of parathyroid hormone surgery on the renal, cardiovascular, and quality of life in terms of normocalcemic hyperparathyroidism. So what is the recommendation on how should the normocalcemic hyperparathyroidism be managed? The panel recommended that you should refer this patient to experienced endocrinologist, and this is the advice. Because we have limited data, it keeps us with no guideline on the definitive indication for surgery in this population. The preoperative localization studies are less successful than in the hypercalcemic disease, but are necessary, whatever, in those who are going for parathyroid surgery. So if the patient was the natural history or was followed without parathyroid surgery, and this was done years back, and they followed the patient with primary hyperparathyroidism for over 15 years. So what happened in terms of biochemical changes? They remain stable up to the year 10, or after that in the year 11 and 13, it's the calcium started to creep up again, and the parathyroid, of course, is stable. And so the patient become to be more hypercalcemic and more symptomatic after the year 10. Not only that, not only biochemical, but also in terms of bone mineral density, the patient really keep stable in the first 10 years, but after that, his bone mineral density start to decrease. So with that, it is recommended that if the patient is not for surgery and he elected to be followed for years, we have to be cautious after the year 10, because the patient biochemically and BMD start to worsen with that in that period, in that years. And it has been shown that 37% of that year in that population cohort of the study, the 37% of them, they developed one or more indication for surgery during the 15 years of monitoring. And this complication maybe, or indication of surgery, may be hypercalcemia or hypercalciuria, or there is a reduction in the bone mineral density. So with that, surgery become an essential. So if the patient is not candidate for surgery, or there are some pharmacological therapy that can be used or studied, and these include the estrogen, raloxifene, but both of these, they are not FDA approved for this indication, as well as the denosumab is not approved yet for this indication as a treatment of primary hyperparathyroidism. So the estrogen and the hormone, they just may decrease the serum calcium. And bisphosphonate, it showed that it improved the bone mineral density, but its effect is neutral in the serum calcium and parathyroid hormone. And the bisphosphonate, that was used in the studies was the alendronate particular. The cinacalcet, it may reduce the serum calcium, but it doesn't have any effect in the bone mineral density. It may just reduce the parathyroid hormone and may reduce the calcium to the normal level even. There are limited cohort that study that took or received the cinacalcet combination of cinacalcet and bisphosphonate, and it showed that the serum calcium is decreased with the improvement of the bone mineral density and decrease in the parathyroid hormone. But even with the improvement of the bone mineral density, we do not have data that it may increase or decrease the fracture risk. The denosumab, again, I said it's not FDA approved yet for primary hyperparathyroidism, but it showed that with some small studies, it showed that again, like the anti-resorptive bisphosphonate, it improved the bone mineral density, but it has no effect on the serum calcium or parathyroid hormone. And of course, these are limited for patients who are not fit for surgery and who has the elevated PTH and elevated calcium and low of bone mineral density. But because other than that, it is recommended to discuss the surgical approach with the patient if he has this complication. So what is the monitoring plan is recommended for the patient who did not undergo surgery. Of course, the serum calcium should be done annually. The skeletal side should be evaluated using 3-site DEXA scan every 1 to 2 years, and to do a CT scan or vertebral fracture assessment if clinically indicated. As the patient come with back ache, or you suspect of loss of height and suspect vertebral fracture. Renal should be evaluated annually with doing the creatinine clearance, and we have to assess also for stone risk factors by doing 24-hour calcium, phosphate, or urea, and if clinically indicated. And of course, annually you have to do the abdominal imaging by X-ray or CT scan or ultrasound if indicated by the patient. So in summary, or the key points from this, we know that primary hyperparathyroidism is a common endocrine disorder, and we have 3 asymptomatic hyperparathyroidism is the most often seen in developed countries because of the introduction of the calcium screening in the panel of the biochemistry. And we know now that there are 3 phenotypes: symptomatic hyperparathyroidism, asymptomatic hyperparathyroidism, and normocalcemic hyperparathyroidism. The relative proportion of all these phenotypes depend on the common medical practice, like screening, and surgery can be recommended even in patients who do not meet the guidelines if there is no contraindication. And for patients who are not going for surgery, conservative medical management is appropriate, and these pharmacological interventions is generally reserved for patients whose serum calcium is high or those whose BMD is low, and surgery is not an option in his case. Long-term conservative management beyond 10 years is advised with caution, because beyond that years, we may see the complication of lowering or decreasing the bone mineral density and worsening of the biochemical finding. With that, I would like to thank you all for listening, and I would just leave this because this is the main reference of my topic, and it is very updated, just published in August. And thank you.
Thank you, Dr. Aidaros, for the nice overview. Again, I'm reminding everybody, you can put the questions in the question and answer section box. So our next speaker is Dr. Thamer El-Aissi. Dr. Thamer is a consultant endocrinologist and the head of division of endocrinology, diabetes, and metabolism in Jabir Al-Ahmed Hospital, and is also a clinical staff at Dasman Diabetes Institute. Dr. Thamer is going to talk to us today about management of hypoparathyroidism. Dr. Thamer, it's nice to see you, and the stage is yours.
Thank you, Dr. Mohammed. Very nice to meet you here virtually. Thank you for the setup, and welcome all for the audience. I'll be delighted to share with you my slides. So let's restart right here. Okay, so I'm here to speak basically about what the opposite was been described so far, which is this is the management of hypoparathyroidism. And here we go. So, okay, so hypoparathyroidism is a rare disorder, definitely rare than hyperparathyroidism. The estimated prevalence is somewhere between about 23 to 37 per 100,000 cases per year, percent in years. It's characterized by three important things: hypocalcemia, hyperphosphatemia, and low or inappropriately normal level of PTH. The most commonly occurs as a complication of anterior neck surgery. There's almost 80% of all the cases of hypoparathyroidism is because of anterior neck surgery complications, and therefore seen more frequently in women and older women, since more commonly in older women to go for thyroid surgery specifically, and they are more prone for this complication or side effects related to the surgery itself. So the mechanism of parathyroid hormone level, and I'm sure this was described also in the previous talk, is that the main issue is with the chief cells in the parathyroid cells. Now, the important part of that is the calcium sensing receptors, because this is the mechanism which actually triggers the release of parathyroid hormone. In ambient low calcium environments, there is an inactivation of the calcium sensing receptor. And with this inactivation, there will be a release of the parathyroid hormone to try to improve the low calcium environment in the circulation. The parathyroid hormone does three actions: try to improve the calcium in the systemic circulation by increasing bone resorption. It does a direct effect on increasing calcium reabsorption from the kidney and decreasing also the phosphate reabsorption. And also it helps with the activation of vitamin D to 125 dihydroxy vitamin D, which is indirectly by the PTH action, indirectly activated form of vitamin D increases calcium and also a phosphate absorption, both from the intestines. So this is usually how the action works. Now, the main issues with hypoparathyroidism is that these parathyroids are destroyed and gone. We'll talk about causes. And this calcium sensing receptor has an issue with functioning, leading to the inappropriate secretion or not secreting parathyroid hormone. So post-surgical hypoparathyroidism, since it's the most important risk factors for or cause for hypoparathyroidism, it's important to know what could be risk factors for developing permanent hypoparathyroidism in patient going for anterior neck surgery. So if someone has an extensive neck dissection or neck exploration, especially bilaterally, then he's at more risk for permanent hypoparathyroidism. If he had a repeated neck surgery, if he had Graves' disease and had surgery done for that, inability to visualize the parathyroid glands, and by that there would be an issue removing some of those parathyroid glands because of inappropriate isolation. Calcium level post-operatively, 24 hours later, if it's lower than 1.88 millimoles, then this is probably an indication that this patient will go through more of a permanent hypocalcemia and permanent hypoparathyroidism. Post-operative bleeding resulting in additional surgery, that's also a risk factor. If the parathyroid hormone value above 10 or above 1 picomole or more than 10 picogram in the 12 to 24 hours post-surgery, then the development of permanent hypoparathyroidism would be very unlikely. So measurement of serum calcium and PTH following surgery is crucial because you can anticipate if the patient will go into more long-standing hypoparathyroidism and also hypocalcemia. The overall incidence of hypoparathyroidism after anterior neck surgery is approximately 8% of cases going for those kind of surgery. And about 75% of cases do resolve within about 6 months, but there is a remaining about 25%, they result in permanent hypoparathyroidism. What are the other causes of hypoparathyroidism? So you have idiopathic, which is most of the time is either autoimmune, or we can actually diagnose them as an autoimmune disease. And this could be an isolated form, or it could be part of an associated of polyendocrine failure, which we'll talk about in the next few slides. Functional, like magnesium deficiency or even excess, both of them will disturb the action of PTH, either decrease in the secretion or with magnesium deficiency causes a PTH resistance. So even though there might be enough PTH, but that PTH would be resistant for the action. Newborns with mothers who would have hyperparathyroidism because that would suppress the PTH in the newborn, developing into hypocalcemia. Genetic diseases are common. They're not very common, but they are an important role in playing in the developing of hyperparathyroidism. So Dysgeuger syndrome, forming aplasia or dysgenesis of the parathyroid and thymus, activating mutation of the calcium sensing receptor, causing inhibition of release of parathyroid hormone, and PTH gene mutation, making an inability to function. Transiently, like burn sites, burn injuries, and acute illness can also cause a temporary hypoparathyroidism. Proliferative disorders like iron deposition with hemochromatosis, sidrosis, and thalassemia, copper deposits in Wilson disease, aluminum deposits in renal disease or aluminum exposure, carcinoma with metastasis to the parathyroids, or even amyloid and sarcoidosis. Absent parathyroid gland, which is also could be a genetic, something related to the genetic malformation, radiation to the neck, like especially external beam radiation, and resistant to parathyroid hormone could be a relative resistant or an absolute resistant. And this could be formed as part of the pseudo-hypoparathyroidism, which we'll talk about. Renal failure also can cause that, and magnesium deficiency, as we mentioned, including the prolonged use of PPI therapy also can induce that. Also, calcium mimetics, which is the cinacalcid, for example, they suppress, they work on activating the calcium sensing receptor, driving the PTH to be lower. This decline, even though it's used in cases with hyperparathyroidism, but overdose or excess dose or inappropriate dose can lead to hypoparathyroidism and then hypocalcemia. So what about the autoimmune hypoparathyroidism? So it's the most common cause of non-surgical hypoparathyroidism. It could occur as an isolated or part of the autoimmune polyendocrine syndrome, or we call it APS1, which is caused also by mutations in the AIR gene or the autoimmune regulator gene called AIR. And this is responsible for forming this polyendocrine syndrome 1. It's characterized by this syndrome is development of chronic mucocutaneous candidiasis, responsible for developing of hypoparathyroidism that occurs in vast majority of patients who does have APS1, and also can cause adrenal insufficiency because it also can act on other endocrine organs, as we mentioned. The clinical features of autoimmune polyendocrine syndrome, or APS1, as we mentioned, mucocutaneous candidiasis, hypoparathyroidism, and adrenal insufficiency. But also minor features could occur because of other autoimmune hits towards the body, and also including some of them related to endocrine organs. A lot of them are inflammatory changes like keratitis, hepatitis, or primary ovarian failure, which is also autoimmune, photophobia, pneumonitis, nephritis, pancreatitis, type 1 diabetes. Also, as you can see here, celiac disease, thyroiditis, so you get, and polyarthritis. So you can see multiple organs are defective because of autoimmune function causing this inflammatory response. The diagnosis of APS1 is probable if you had the presence of at least one major syndrome, which we mentioned here, either mucocutaneous candidiasis, hypoparathyroidism, adrenal insufficiency, with positive antibodies to type 1 interferons, which is molecule produced by the immune cells, which is abundantly present in patients with APS1. Also, you could see some other antibodies, like antibodies to 21-hydroxylate, which correlates well for the development of adrenal insufficiency, and also antibodies to NAO5 and activating antibodies to the calcium sensing receptor. Both of them are indicative for the development of hypoparathyroidism. So these are some antibodies you can order to look for the possibility of developing hypoparathyroidism. In genetic variants, you could have an isolated hypoparathyroidism, and that could happen in the glial cell missing gene, GSM2 gene. In that location, you would have a mutation that results in a parathyroid gland agenesis completely. Also, you could have an autosomal dominant hypocalcemia, and this is also genetically inherited. There's two types of the ADH, type 1 and type 2. Type 1 caused by activating mutation in the calcium sensing receptor, causing suppression of PTH synthesis and enhance the urine calcium loss. Type 2 also caused by activating mutation by a different gene called GNA11 gene, causing also again suppression of PTH, but at this time not causing urine calcium excretion to be affected. Also, you can have PTH gene mutation itself that's causing defective synthesis and the secretion of the hormone itself as PTH. There's also genetic variants, which is causing hypoparathyroidism plus additional features like DiGeorge syndrome, for example. It's a rare condition, and 7 to 80% carry microdeletion of chromosome 22. If someone has DiGeorge syndrome, they could have developmental delay, palatal anomalies, parathyroid aplasia and hypoplasia, causing hypoparathyroidism and hypocalcemia, aplastic and hypoplastic thymus with immune deficiencies, congenital heart disease, facial anomalies, speech and learning disabilities. Also, they could have hypoparathyroidism with sensorineuronal deafness and renal dysplasia syndrome, or called HDR syndrome, also genetic variant with more than just hypoparathyroidism. It's a very rare autosomal dominant disorder. Mutations in the GATA binding protein 3 gene. This is localized in region 10. Clinical features would be hypocalcemia because of hypoparathyroidism. Because of sensorineuronal deafness, you could have a hearing loss and renal disease because of dysplasia. Also, HRD syndrome, which is hypoparathyroidism with retardation dysmorphism. This is also rare autosomal recessive hypoparathyroidism. Patients could have congenital hypoparathyroidism, severe growth impairment, mental retardation, and facial dimorphism. Another part of causing or having a deficiency in the action of the parathyroid hormone is developing PTH resistant syndrome. So even though these patients could have a normal secretion of the PTH, but they develop resistant to the PTH action, causing features of hypoparathyroidism, whereas these patients could have an increased level of serum PTH. So pseudo-hypoparathyroidism, they are a heterogeneous group of disorders. They're characterized by hypocalcemia and hyperphosphatemia, but they had an increased serum PTH, not hypoparathyroidism. But they develop same picture of someone who could have hypoparathyroidism with low calcium and high phosphorus level. Pathology is PTH resistant. The main cause for gene mutation is the GNAS 1, which encodes for the alpha subunits of the stimulatory G protein where the PTH actually binds in the cells. It's an autosomal dominant inheritance, depending different presentation if it's from maternal or paternal. It's a rare. Overall prevalence is 7 in 1 million, approximately 1 in 140,000. Females more than males, 2-to-1 ratio. Associated with pseudo-hypoparathyroidism is very characteristic Albright's hereditary osteodystrophy, which could be a feature of type 1A pseudo-hypoparathyroidism, and also the pseudo-hypoparathyroidism. In these patients who would have Albright's hereditary osteodystrophy, they could have round faces. You can see the picture on the left, short fourth metacarpal bones, obesity, subcutaneous calcifications, developmental delay, osteitis fibrosa, and you can see it on X-rays, and hypothyroidism, gonadal dysfunction, and short stature, which means that there are other hormones involved in developing this condition. This is a table describing multiple types of pseudo-hypoparathyroidism, depending on mutation. Type 1 and pseudo-hypoparathyroidism, both of them have the AHO phenotype, which we described. And some 1A could have other hormone resistant involved, like thyroid and other hormones. And both of them have the same mutation in the same gene, but the inheritance would be different. So if it's maternal inheritance, patient would have type 1A. If it's paternal inheritance, it will be pseudo-hypoparathyroidism. Now, there are other forms like 1B, 1C, and 2, less described, less common than the 1A and pseudo-hypoparathyroidism. Here we're describing nephrogenic cyclic A and B response to PTH, describing if the resistance is also including in the kidney or not. And this is one way of differentiating some of these types of pseudo-hypoparathyroidism. So if you give PTH looking for cyclic A and B, some of them have a decreased level, some of them are normal. This is also some way of differentiating these types of pseudo-hypoparathyroidisms. The treatment part, if you have a patient with pseudo-hypoparathyroidism, the treatment goal is to try to normalize the calcium, but also at the same time avoid the hypercalciuria and the nephrocalcinosis. And you need to monitor other hormones, especially gonadal and thyroid, because some of these conditions could be associated with resistance to other hormones. Calcium replacement is important, 1 to 3 grams of elemental calcium daily. Vitamin D, either calcitriol and also ergocalciferol are important as a replacement. Thiazide directives, you can use that to lower the hypercalciuria. Phosphate binders also can be used to improve the features of this disease. What about going back to the general hypoparathyroidism? the things that we saw described either surgical or autoimmune, which is the most common two types related to hypoparathyroidism. So what would be the acute symptoms and features of hypoparathyroidism? And depending if the presentation is an acute or chronic. Acute, you might find that in patients with post-surgical hypoparathyroidism causing acute or subacute hypocalcemia. Chronic, most likely you will find that in patients with autoimmune because the duration of onset of these symptoms are very long and they present with a chronic illness. So acute changes, they could have neuromuscular irritability, which is the most common presentation, like tetany. They could have paresthesias, muscle twitching, carpopedal spasm, the characteristic features of tridose and trophistic signs, seizures even, and you can have spasm in the bronchus and the larynges. And this could be an emergency condition. You need to act fast. Cardiac changes, you can find them in acute hypocalcemia with the hypoparathyroidism, like prolonged QT intervals, hypotension, heart failure, arrhythmias, and you could find papilledema. In chronic changes, because this has been going on for a very long time, you can have ectopic calcification, especially in the basal ganglia. And a lot of patients are actually neurological that are extrapyramidal. So you can have these involuntary movement disorders like dystonia, hemibilismus, choreothesiosis, oculogyric crises. All these are involuntary movement disorders that could develop because of this deposition and involvement of the extrapyramidal features. Also, they could have Parkinsonism, dementia, subcapsular cataracts, abnormal dentition, and also dry skin because of this condition. The most common complication related to chronic hypoparathyroidism, which we can see with chronic surgical or even chronic non-surgical, are most commonly would be a cataract. And prevalence about almost a quarter of patients would develop that. Less commonly would be infections, nephrocalcinosis or nephrotheliosis, renal insufficiency, seizures, depression, ischemic heart disease, or even arrhythmias. So how to diagnose hypoparathyroidism? So there are baseline testing. You want to do them in all patients you're suspecting that they could have hypoparathyroidism. Definitely want to do an intact PTH. You want to do serum albumin adjusted calcium, or you can do ionized calcium instead of serum albumin adjusted calcium, or you can use the ionized calcium as a confirmatory test if it's needed, plus the serum phosphorus. So this is a basic test. You can diagnose patients with hypoparathyroidism based only on these features of tests. The additional tests are based on the clinical presentation and where do you suspect. So magnesium, if you're suspecting hypomagnesemia causing PTH resistance. Renal function, definitely if you're thinking of nephrocalcinosis, nephrotheliosis affecting the kidney function. Autoantibodies, if you're thinking of the PAS1, as we described, the polyglandular. Pancreatic enzymes in case of pancreatitis, which is one of the features or one of the causes of hypocalcemia. Bone markers like osteoplastic metastasis, also causing features related to that. ACTH, cortisol, and TSH values, all of it because of polyglandular failure. You want to evaluate vitamin D, most likely you will do that, whether activated form or total vitamin D in deficiency states. Imaging for bone disease like osteomalacia, calcinosis, and infiltrative parathyroid disease, you also can suspect with imaging to do that. Genetics, you probably want to do genetic testing if you have a positive family history, patient present with syndromic features, or if the age is less than 40, predicting this is a genetic disease. There you want to look for genetic testing. So in patients who have a hypoparathyroidism, the goal of therapy would be what? Relieve symptoms which are related to low calcium, raise and maintain the serum calcium concentration in the low normal range, not completely normal, prevent iatrogenic, hypercalciuria. So you want the 24-hour urine calcium to be less than 250 in adult women and less than 300 milligrams for adult men. That keeps it safe from developing calcinosis in the kidney. You can use or not need to use the thiazide diuretics based on the how much calcium you have in the urine, how much you can lower that with thiazide diuretics. Do you want to avoid hyperphosphatemia? You want to try to normalize plasma magnesium so it wouldn't affect the level of calcium and PTH, and try to avoid, try to achieve vitamin D level, in the normal range between 75 and 125 nanomoles per liter. In emergency setting, in patients with severe acute hypocalcemia, here you want to act fast. So in case of a cardiac, respiratory, or a significant neurological symptoms, or if the albumin-adjusted calcium less than 1.75 here, or 7 milligrams, here you want to act fast. So you want to give bolus IV calcium. You can give it as a 90 to 180 milligram of elemental calcium over 10 to 20 minutes, and requires that cardiac monitoring to be on the safe side because of changes in QT intervals. And this is arrhythmias. And this is followed by an IV calcium infusion. And this can be initiated with oral therapy and with calcium and calcitriol at the same time when you're doing the IV calcium infusion. Calcium infusion, you can give 10 ampules or about almost 100 milligrams of elemental calcium. The 10 ampules gives you in 1 liter of 5% dextrose or even normal saline at 50 ml per hour. And you can titrate according to serum calcium level until you're optimized on the oral calcium and the oral calcitriol. Initiate an active vitamin D metabolite, as we mentioned, the calcitriol or even alpha calcidiol. You can either one, you can use them. With calcitriol, you can do 0.25 microgram twice daily. We can go up even to 0.5 twice a day as total 1 microgram, even more than that if it's required. But keep in mind, as you go higher on the active vitamin D, you're probably going to dump calcium more in the urine and causing hypercalciuria. This is the conventional therapy for hyperparathyroidism. We already described them. So calcium is required. You can use it as a calcium carbonate or calcium citrate. The ranges would be somewhere between 500 to 3 grams 3 times a day, preferably given with meals. This is to enhance the phosphate binding effect of this calcium. Calcium citrate is preferred in patients with PPI use because it doesn't require pH changes to actually does the job. Calcium carbonate would be the other option. Vitamin D, you can do vitamin D3 with cholecalciferol or ergocalciferol D2. The majority of time, D3 is more preferred. You can do any doses available. You want what you want to do with these doses, whether you want to do a daily dose, a weekly dose, a monthly dose, whatever the dose you want to use, you want to maintain normal vitamin D level. And then with calcitriol and alpha calcidiol, the doses are mentioned here is 0.25 up to 3 times per day. You can go up to 1 microgram, even more if it's required. Alpha calcidiol, 0.5 microgram up to 6 microgram daily. These drugs have a short half-life. You can titrate them throughout the day, give them several times during the day to optimize the calcium level. Thiazide diuretics, you can give it in a dose between 25 to 100 milligram, and the half-life is between 6 to 12 hours. That's helpful for, you can do it once or twice a day. Once a day to optimize also the calcium in the urine. With PTH replacement therapy, there are certain considerations for you. So this would be a therapy that you probably want to think of beyond using the conventional treatment. So patient not adequately controlled on the conventional therapy, meaning that they have still symptomatic hypocalcemia, they still have hyperphosphatemia, they do develop renal insufficiency, hypercalciuria, and even poor quality of life, because a lot of these patients take about 6, 8, even more calcium tablets with activated form of vitamin D, with vitamin D, and even magnesium. So all their life is taking just full of pills. This is not really an optimal quality of life. So here comes in using these parathyroid hormones. So individuals with poor compliance, also malabsorption, or are intolerant to large doses of calcium and active vitamin D also could be a good choice for using this therapy. Individuals requiring high doses of conventional therapy, like calcium doses more than 2 grams a day, or active form of vitamin D more than 2 micrograms a day, that's also an indication to use these levels. With parathyroid replacement, there are 2 types of we can do it. So the parathyroid hormone is a 84 amino acid polypeptide hormone. The fully active region is in the first sequence of 34 amino acids. So the one available for current use is the teriparatide. And teriparatide as a human PTH 134 has been used in these kind of cases. It does improve the calcium, so it increases serum calcium. It lowers urine calcium excretion and increase in phosphate excretion. But the problem is that it's a half-life of the 134 is short. So you need to give it on a daily injection twice a day or even on a fusion pump. So that's why the 134 available is not really currently used to treat hypoparathyroidism, but rather for osteoporosis. What's available is the recombinant human 184, which is the full length of the parathyroid hormone. It's longer duration half-life, longer and can be administered as a 1 daily dose. It's a well-tolerated drug. It reduces the need for calcium and calcitriol. It reduces the serum phosphorus, and in long-term studies also lowered the urinary calcium excretion. The main trial was used with the 184 was the REPLACE trial. 134 patients with chronic hypoparathyroidism, half of them were given the 184 parathyroid hormone, the others were given placebo. This is looking at the outcome of patients reducing their oral calcium by more than 50% and also reducing calcitriol dose while maintaining normal calcium level. These patients reached about 53% of them on drug, and on placebo only 2%. So you can achieve patients with much lower oral calcium, lower calcitriol with normal calcium with the use of this drug in this condition. This is another factor looking at normal calcium independent from active vitamin D and reduced oral calcium, meaning that these patients in red have achieved normal calcium with no active vitamin D and reduced oral calcium. And these patients reached about 40% on the drug versus almost 2% on placebo. And this is also looking at the mean calcium dose. Patients on the drug have reduced their mean calcium dose to somewhere around 1,000, whereas in the placebo about 2,000. And also here, the active dose of vitamin D also reduced with the drug to be somewhere around 0.25, whereas on the placebo around 0.5. So you can achieve lower calcium need, lower activated form of vitamin D need. In terms of safety, generally well tolerated. It can cause some hypocalcemia, some muscle spasm, paresthesias, headache, and some nausea, the most common adverse events. There was also some evidence of hypercalcemia with the treatment, causing over-treatment of correcting of calcium, about 18% of incidents developing hypercalcemia. In terms of serious or severe side effects, it was the two ratios or the two arms were equal in the ratio of severe forms. So the recombinant therapy was approved in the FDA in 2015, as well in EMEA for the management of hypoparathyroidism. But in 2019, the FDA has recalled all the stock of the recombinant 84 due to the possibility of the presence of rubber particles originating from the cartilage septum. This recall has not done in Europe, so it's still available in Europe, but not in the US. Another drug in the work right now called TransCon PTH. TransCon PTH is actually carrying a patent drug of 134. So it's actually the active form or the active free sequence of the parathyroid hormone. Here, they want to overcome the problem of the short-acting effect. So where they linked it to a TransCon carrier, which is this helical part, and they linked it together. And that linkage, if it's injected in the subcutaneous tissue, that linkage will cleave, releasing the active PTH, and that will have the half-life of the drug much longer than the previous sequence. And that helps to maintain the drug and give it on a daily as a single dose every 24 hours. There was one trial done as a phase 2 trial, the Path Forward. There was about only 59 subjects. They randomized to 4 arms, 3 drug doses of the TransCon PTH, either 15 microgram, 18 or 21 microgram per day, and the 4th group was a placebo. They followed these patients randomly, blinded, for the 4 weeks, and then they opened them as an open label for up to 26 weeks. So the data I'm presenting is up to 26 weeks, with further data expected later on up to 214 weeks. This data was published early in 2022. By week 4, patients treated with this drug, about 50% of them have achieved primary endpoint, which is normal calcium level with less dependency on calcium tablets and activated form of vitamin D. 82% of them treated with the drug have able to stop completely oral active vitamin D and reduce the calcium supplementation to less than 50 milligram per day or even less. 50% treated with the drug achieved a complete independence from conventional treatments, which is vitamin D and also calcium. So that's by 4 weeks. Waiting for 26 weeks, which is here the open label phase have started, 91% treated with the TransCon PTH, they achieved independence from the standard of care, which is calcium, very low dose, less than 500, and no activated vitamin D form. 76% of individuals eliminated completely the active vitamin D and calcium entirely at that point. And the median dose that was used was the 18 microgram, seems the appropriate dose that achieved majority of this effect. This is to show the 24-hour urine calcium also significantly declined in patients receiving the TransCon therapy from 400 milligrams, which is elevated, to 178 as a mean, which was normal. And here looking for the physical and mental summaries, this is a quality of life issue. And they looked here at the baseline and at 4 weeks with the TransCon therapy placebo, showing the effect that there is a significant difference between the patient using the drug, patient using the placebo. Patient using the drug had a higher quality of life parameters compared to the placebo. This is occurred in the mental component summary and the physical component summary of the questionnaire. The safety of the TransCon, no serious adverse events related to the study, and no adverse event led to the treatment discontinuation. The most common adverse events noted were headaches, nausea, fatigue, some hypertension, arthralgias, hypocalcemia, spasms, and UTIs. Nothing really major. And no related side effects to hypocalcemia and hypercalcemia required an urgent care to be done on these patients. This is a summary of the trials that used additional or the PTH hormone therapies compared to conventional. These trials generally, when used PTH hormone therapy, they showed a reduction in the dose of calcium and activated vitamin D by more than 50% in majority of the patients, reduction in serum phosphorus, small benefit in quality of life, but still it's there. Increase in the episodes of hypercalcemia, though this is something to really watch for in patients using these PTH because you can correct the hypocalcemia. Well tolerated with very infrequent serious adverse events occurring with these patients. The opt-in monitoring for patients who have a chronic hypoparathyroidism, you want to measure serum creatinine, GFR, calcium, magnesium, and minerals every 3 to 12 months. Vitamin D, maybe 6 to 12 months, and 24-hour urine calcium and creatinine, maybe FT 6 to 24 months. Few slides on pregnancy and lactation with the role of parathyroid hormone. So patients, when they're pregnant, usually their calcium level goes down because of volume expansion. But there is another factor that actually triggers the improvement of calcium level, which is the PTHrB, which is produced by the placenta and the breast, which can help vitamin D form into an activated form of vitamin D. It can also increase calcium intestinal level and phosphate absorption, increasing also urine calcium. When hypocalcemia develops during pregnancy, this could be associated with uterine contractions, increased risk of labor and miscarriages, and can also cause fetal secondary hyperparathyroidism with the stimulation of the hyperparathyroidism in the fetus. Maternal hypercalcemia can cause suppression of the fetal parathyroid gland, developing a transient hypocalcemia in the fetus after delivery. This is a case series looking at if patients with chronic hypoparathyroidism during pregnancy, were the doses of conventional therapy, that is calcium and vitamin D, change or not if they get pregnant. As an overall, from this small trial, the average dose of vitamin D and calcium did not really change significantly during pregnancy, but still the dose of calcium and vitamin D adjustment by about more than 20% required in about 50% of pregnancy. So some patients, while you follow them, some of them require that you increases the dose of activated vitamin D and calcium, but in majority, they probably will stay around the same level. So during pregnancy, how you can manage them, calcium and vitamin D and activated vitamin D analog, they're safe. You can administer them during pregnancy. Thiazide diuretics, PTH hormones, You cannot, they're not advised because they're still category C, B, and C. You want to maintain serum calcium adjusted for albumin at the low normal level, close monitoring with labs every 3 to 4 weeks, and any changes in the dose you do, especially in the calcitriol, you want to repeat the test in 2-3 days, make sure it's appropriate. There are emerging therapies are going right now. We already talked about TransCon. Now it's going into phase 3. There is something called long-acting PTH analog. This is a hybrid molecule between PTH and PTH-RB. Oral PTH molecule with 134, also in development. And calcilytics, they are antagonizing the calcium sensing receptor. They could be done in patients with autosomal dominant hypoparathyroidism. So in conclusion, hypoparathyroidism is a rare condition, especially with chronic type, but with great implications on quality of life. Evaluate the risk factors for surgical hypoparathyroidism to reduce the incidence of long-term complications of hypocalcemia. You want to identify patients with the highest risk for familial hypoparathyroidism and also hypocalcemia. In patients with chronic hypoparathyroidism, conventional therapy is still the first-line therapy. When conventional therapy is deemed unsatisfactory, you want to consider use of PTH. A coordinated care approach is advised when dealing with hypoparathyroidism during pregnancy. And with that, I end my presentation. Thank you so much for your attention.
Dr. Thamer, thank you very much for the nice overview, very comprehensive. And if I can get Dr. Salwa as well online, can I see Dr. Salwa? Is Dr. Salwa with us? Right. Assalamu alaikum, Dr. Salwa. Your speaker is mute. Can you just unmute yourself?
Yeah.
Assalamu alaikum, Dr. Aidaros. How are you doing?
Dr. Salwa.
Good.
كيف حالك دكتور سلمى؟ العافية جميعا.
Good. So it was a very nice overview by both speakers, and I can tell you we have lots of questions. However, for the sake of time, we're going to have 10 minutes for discussion. So I've selected 3 questions in order to address for the audience. So Dr. Salwa, one of the questions is related to osteoporosis secondary to hyperparathyroidism. The question is, if patients with hyperparathyroidism who have osteoporosis are gone for surgery, do you need to use anti-resorptive therapy, or will it improve after the treatment of hyperparathyroidism?
In fact, yes, the cure or the remission of the bone profile is the case after parathyroidectomy. So actually, you do not need it if the surgery is in the near future. So it's better to do the surgery, and we're going to expect the improvement to almost 90% to normal of the bone mineral density after the post-parathyroidectomy. So no need to give anti-resorptive therapy or any osteoporosis specific therapy for patients going for parathyroidectomy.
So the second question is related to the use of senecalcet. So you mentioned senecalcet in your talk. However, the audience, I would like to know when do you use it, and how do you use it, and how do you monitor it?
Okay, so this is indicated. This is the medical treatment in general for the hyperparathyroidism, indicated for the patient who has really he's not candidate for surgery, and he needs this medication. So with high PTH, you may use the senecalcet if the patient is not going for surgery. But for patient going for surgery, then you don't need to optimize anything apart from the vitamin D. Just optimize the vitamin D prior to the operation and awaiting for the operation. But rather than that, any of the medical therapy that I've mentioned, it is just small studies, and it is indicated only for patients who are symptomatic and not candidate for surgery. So you can use the senecalcet, and you're gonna monitor you're gonna expect that the calcium maybe go to the normal, but there is no much effect on the bone density. And if the combination therapy, again, there are small cohorts, and you can use both the senecalcet as well as the anti-resorptive therapy just to improve the biochemical profile of the patient.
That's great, thank you. Dr. Thamer, You have stressed in your talk the two things, which I think is really important relating to the management. The fact that you don't need to normalize or get the calcium normal levels back to normal, and the fact that you need to monitor the urinary calcium at 24 hours urine collection for calcium, which is one of the problems. I'm not sure if you face that you see a lot of patients who are not ever get a 24 hours urine collection. And there's a question here which is interesting. How much of the complications that you just mentioned related to hypoparathyroidism are actually due to the disease itself or due to the overtreatment of the disease?
Good question. I don't think this was estimated well, but definitely when we decide on a proper follow-up, we definitely anticipate there would be a complication related to overtreatment. That's why we have the tools designed to look for over calcium level. We don't want to overtreat the calcium or normalize it very well. That's why we recommend in the monitoring of urine calcium. That's why we recommend using thiazide diuretics in cases you cannot really control it well. So we know this can occur. I'm not sure if there's a value that I can mention, but this is anticipated and we want to prevent it. And keeping in mind also, I mean, these conditions are lifelong, and this is not something that can be cured. So you want to monitor that for the future also.
And there is a question related to post-op hypoparathyroidism. So you just mentioned certain levels and certain cutoff points after the surgery that can predict what patients can actually end up with hypoparathyroidism. And the question is, what is the optimum management on immediately post-op if you suspect that the patient might end up with hypoparathyroidism? Do you cover all your patients with calcium, vitamin D, or you select your patients?
So actually what I would like to do, I'll always try to do, is listen to the surgeon, because the surgeon can give you hints of what happened in the OR. If you have a luxury to read the OR notes immediately post-op, that would be even great, because you can appreciate how much dissection was there, where the parathyroid was identified and isolated. All that gives you confidence is how much a post-op hypocalcemia can develop versus no hypocalcemia can develop. Definitely, you want to monitor still the calcium level post-operatively within 12 to 24 hours. Levels that are declining, not necessarily that predicts that this is a permanent hypoparathyroidism, unless it's actually much lower. We came up with, the literature came up with a level that it says about less than 1.7 or less than 1.8 millimoles. So this could be one of the levels. It's still a level of PTH that you can see and evaluate that is more than 10 micrograms. This could be a level that tells you this is possibly patients can have a recovery of his parathyroid hormone. Now, keeping in mind, with all that said, there is a manipulation that can happen in the parathyroid during the surgery itself. So even the pathology that was removed, especially if you're taking out a thyroid, for example, tells you that there is no parathyroid has been removed. The surgeon has identified them well and kept them in the neck. It still could be devascularization can happen, mobilization can happen. That's also affected. Something I didn't really mention, I didn't stress that because I think it's more the surgical than medical, which is transplantation of parathyroids. Now, this is something can happen during the OR, where surgeons have removed, whether they had to or didn't have to, a parathyroid, and then they attempt to transplant it back in the neck. What's recommendation is not to do that, because that parathyroid will not survive. It might cause an issue that you need to go back and do another surgery, and you put the patient at risk for further hypocalcemia and hypoparathyroidism.
Great, thank you. Dr. Salwa, there's a question regarding management of patients with hyperparathyroidism, where you decided they need to go for surgery, but the conventional localization techniques fail to identify a particular target. And the question came actually that surgeons often refuse to operate, and is asking what other localizing techniques can you actually do? I remember you said the surgeon hand is the best localizing technique, but I let you comment here. Can you unmute yourself, please?
Yes. Okay. So the best, in fact, really, and I never met a surgeon that refused the surgery. They like and they ask us just to send the patients. But anyway, the surgeon hand is the best tool. But we can use the system EB scan, the ultrasound of the kidney, or CT scan sometimes, just to localize the hyperparathyroidism. But in fact, in practice, really, I found that the surgeon hand is the best. With the exploration, even sometimes we fail to localize, even with the parathyroid scan, we could fail to localize the parathyroid adenoma. But then after the exploration by the surgeon, they identify it and take it. But any of the mean of the imaging, CT scan, ultrasound system, maybe they can do that.
That's great. Dr. Thamer, there is a question here and talking about patients who on treatment, but they're still having lower calcium levels. And they particularly put a set point over in the question, talking about patient with calcium levels of about 1.7 millimole per liter. And the question actually, if those patients with low calcium levels are completely asymptomatic, do you need to treat them with IV calcium if their calcium levels are on the boots, or what do you need to do?
IV calcium is usually only for urgent cases, and very hard to see that with chronic hypoparathyroidism unless they're in a situation that's very stressful that requires them or leads to further calcium decline, meaning patients being sick in an ICU and a trauma, have been through a surgery. That's probably will lead to further decline in calcium and then need to maintain it with an IV. But usually, majority of time, you don't need the IV since these majority of hypoparathyroid patients are chronic rather than an acute condition.
That's great. Dr. Salwa, there is a question regarding the normal calcemic hyperparathyroidism. And I'm one of those guys who are skeptical about this condition because I think, why will you check a parathyroid levels if the patient has a calcium levels? Why will you actually do that? How you come across to find this condition? And the literature is very vague over here. But there is a question here, is that how do you treat them? So do you actually need to do a localizing? Do you need to send them for surgery, or you just need to monitor them? What do you do when you find them?
Yeah, so normal calcemics, in fact, there is much uncertainty about this normal calcemic hyperparathyroidism. But anyway, we cannot label anyone normal calcemic hyperparathyroidism after excluding all the causes of secondary hyperparathyroidism. As I mentioned, vitamin D, chronic renal failure, medication like thiazide or diuretic, and etc. So if you just done that and the patient is asymptomatic, or say, for example, I will give examples. I have osteoporosis, and usually we come across these patients when we evaluate for something, for a complication like osteoporosis, low BMD, and we do the bone panel and we find normal calcium but high PTH. This is one of the causes that when these patients come to us. So actually here, the medication or indication for surgery. Hello, it is freezed. Can you hear me? Yeah, the medication.
We can hear you. Yeah, please.
Yeah. The surgery is just indicated like the normal, like the classical hypercalcemic hyperparathyroidism. If any of these causes is there, but if the patient come from the beginning with osteoporosis, it is preferable just to look for secondary causes, and you may just follow up the patient. And in fact, we do not have try to localize. If the patient, there is one indication for surgery like the osteoporosis itself, then you have to localize the parathyroid adenoma, parathyroid lesion, because in these small studies, it's found that it is multi-gland in nature. If it is normal calcemic hyperparathyroidism and have these complications, then you have to do the exploration and to do the localization and go for surgery. If the patient does not have complication and you found him just have normal calcemic hyperparathyroidism and you exclude the causes and then the other secondary causes, then you have to follow them up till any of the indication come in life. So is that clear?
That's great.
And in fact, the labeling
that's
should
clear,
be
yeah.
after 6 months. You have to have persistent normal calcium, high PTH for a long period. I mean, at least 6 months, yani, and it is consistently the same finding: high PTH and normal calcium. And during the follow-up, you have to exclude other the secondary cause. You have to look for, because the longest cohort that they followed these patients, maybe for 14 months, 75% of them, they just down the road, they developed any of these secondary causes came up into the surface, and many of them, they just normalize their parathyroid hormone.
Right, it's normal. Yeah, that's great. Dr. Thamir, there is a question regarding pregnancy, but I'm trying to figure out, because the question seems to ask that you said that the parathyroid levels increases during pregnancy, and as you said, there is increased absorption of calcium. And the question says here, why do we need to increase the calcium and vitamin T intake during pregnancy if that's the case? I think that's the way I understood the question.
Oh, no, not the PTH.
I'm not sure if this related to this one. Yeah, okay. Go ahead, please.
It's a PTH-related peptide. That's
PTH-related peptide, yes, correct. Actually,
that is secreted not by the parathyroid tissue, but is actually secreted by the placenta and the breast in pregnancy. So that can sometimes help to maintain an adequate absorption of calcium from the intestines with phosphorus by activating vitamin D. So it's an indirect way to normalize calcium in pregnancy. Now, and that's why we don't have really good trials on evaluating conventional therapies in chronic hypoparathyroidism in pregnancy. But what we can see is that a lot of patients, they don't require changing in the dose. And this could be the reason why that there is another entity, which is the PTH-related peptide, maybe it's helping out and improving some of the calcium levels that the PTH is not really doing because it's not there.
Great. I think we have run a little bit over time, so I think we're going to conclude our session. I would like to thank the audience, first of all, for their participation and for their interaction. I would like to ask both eminent speakers for the really nice talks, and generated a lot of discussion, and it just speaks for itself by the amount of questions that I've been trying to summarize. I would like to thank the Arab Thyroid Association for these nice webinar sessions. And by that, I would conclude and wish everybody a very pleasant evening. So thank you very much for everybody, and have a nice evening. Goodbye.
Thank you.
Bye. Thank you so much. Have a good evening.